A very big hello to all my dear students. So, coming next to in the alphabetical series in your favorite channel, you and I with Dr. Ruchi Rai. Which alphabet? This time it's C. What are we going to learn here? Very important, again repeated question of your every exam. Chiasmal lesions. Okay. So, let's have a look very quickly, revise chiasmal lesions. We all know that chiasma means nasal fibers are decussating, temporal fibers are not, right? So, what are the field defects in a chiasmal lesion? When the lesion is exactly at the decussation of the two nasal fibers, you are going to get, we all know, we understand this, that field defects are always opposite of the anatomy. If nasal fibers are gone, it is going to cause temporal field defect. Temporal is gone, nasal field defect. ये तो ठीक है? So, what is happening here? Very quickly, because this discussion has to be to the point, so I directly go into chiasmal lesions. We will learn mainly two things: central chiasmal lesion, what is anterior junction syndrome, and okay, I'll also talk about what is posterior junction syndrome, right? So, when you say central chiasmal lesion, what you are going to get is bitemporal hemianopia. Okay, right. So, what you are getting when the lesion is at central, we will say we are getting bitemporal where both side temporal is gone. Next, we talk about what happens if the lesion is at the junction of the optic nerve and chiasma. So, if the lesion is somewhere here as shown in this one, now some fibers of the nerve are gone, some fibers of chiasma is gone. You have to understand this way. Nerve fibers of the optic nerve fibers, if they go, it will cause centroscotoma. If all of the optic nerve is gone, it is going to cause blindness. So, one side is either centroscotoma or sometimes even complete blindness. Which side? The side where nerve is involved. And for the chiasmal lesion, you get opposite side superotemporal quadrantopia. Now, why so? This is important. I just told you that the anatomy is opposite to the field effect. So, when I am saying superotemporal quadrantopia, it means the fibers that are involved will be inferonasal. So, let us understand here, these inferonasal fibers are nothing, this is a normal anatomy in the chiasma. These inferonasal fibers, they detour to the opposite side like this and then go into the chiasma. This is what is called anterior Wilbrands knee. Now, if the lesion is here, these inferonasal fibers are damaged. This is the reason I get one side superotemporal quadrantopia, other side central scotoma. Okay. So, this is a very important exam question for you all. You will have to see which side nerve is involved. So, if I say right side central scotoma, left side superotemporal quadrantopia. So, it automatically means that it is if the central scotoma is in the right side, means this side nerve is involved, and the opposite side, it is the chiasmal fibers, that is anterior Wilbrands knee is involved. Okay? Okay. So, this is anterior junction syndrome because it is at the junction of the nerve and chiasma. And what is the other name of this condition? We call it junctional scotoma of Trachar. Trachar is the name of a person. So, this becomes junctional scotoma of Trachar. Right? Okay. Once we know this, we come to the next important thing. What is posterior junction? A very quick one, nobody will ask you much. Posterior junction syndrome. Posterior junction syndrome is nothing but involvement of macular fibers. Since it is mainly the chiasma has heteronymous hemianopia, here what you will see that the patient macula of one side here and one side. So, it is a macular heteronymous lesion. This is what is posterior junction syndrome, where there is a macular heteronymous hemianopia. Okay. So, just remember this much, this is all about chiasmal lesions. Let us solve a few questions here. Heteronymous hemianopia is seen in all except heteronymous. Whenever I taught you, if you have seen your field effects, everything is homonymous. The only field effects which are heteronymous are chiasmal lesions. So, all except chromophore adenoma, bilateral aneurysm of internal carotid artery, occipital lobe lesion, chiasmal lesion. So, of course, this will affect the chiasma, this will affect the chiasma, this is affecting. So, what is the answer? Answer is occipital lobe lesion. Here you do not get heteronymous, what you get is a homonymous hemianopia, is not it? So, we will say, chalo, let us make it little more neater. So, we will say that the answer is occipital lobe lesion, where you are getting homonymous hemianopia. One more question for you all. A patient with a supracell extension of the pituitary tumor presents with, that is going to affect the optic chiasma. Remember your anatomy, pituitary gland, optic chiasma above, and that is just in that diagram below you see what? Cavernous sinuses, right. So, any supracell extension means chiasma is involved. Therefore, what you will answer here is bitemporal hemianopia. Okay. So, this is going to lead to bitemporal hemianopia, right. Okay. So, that was all about your chiasmal lesions, a quick revision of chiasmal lesions, what is central chiasmal lesion, what is anterior junction syndrome, what is posterior junction syndrome, right. Hope you enjoyed the discussion. Thank you so much. Stay blessed and keep smiling.